just adjust this. Okay. I know it's almost lunch, so I'm going to make sure I get you guys out on time, especially coming from the dietitian. Okay, hold on. Okay. And how do I advance the slides? Just in the middle? Okay, perfect. Hold on. Okay. So thank you for that kind introduction, and thank you for having me here today and in person. I think between my years at Stanford Healthcare and now at UCSF and private practice, I believe I know most of you and I worked with most of you. So with that said, today we're going to review the concepts of diet and nutrition in IBD, in which both of them play a very important role in treatment and management of IBD. Here are my disclosures. Okay. So for our focus today, one is that we're going to discuss the role that foods may potentially play in the development of IBD. And then certainly we will learn what malnutrition is and learn the potential contributors to malnutrition. So when present in front of you, it's easily recognizable. And then finally, there's so many different nutrients in the diet and there's only so much time today. So I'm going to bring in a focus on fiber. Overall, to apply practical application on how to add fiber into a diet with a patient who has IBD, as fiber tends to be the nutrient that tends to be usually out of the diet due to fear or whatever reason that we will go over today. Okay, so I decided to use a case-based approach today to really outline some of these concepts. So this is a 27-year-old South Asian male diagnosed with ulcerative colitis, UC, since 2008. So he was diagnosed in his mid-teens, okay? So it's about 10 to 11 years later, he's still dealing with active disease. In review of his medical course with UC, proctosigmoides in 2014, ileitis and terminal ileum in 2015, and now he has colitis from the rectum to the transverse colon, along with presence of hemorrhoids. He reports a weight loss of 32 pounds unintentionally over 8 months. So with him being at 113 pounds and a height of 6'1", he has a BMI of 15, okay? He is very underweight. He has a 22% weight change in 8 months, and this has been deemed nutritionally significant. You'll find dietitians calculate weight changes all the time in the notes because a nutritionally significant weight change, it has met a certain perimeter that malnutrition could be likely present. He expresses a desire to gain weight in complete agreement. I do want him to gain weight as well. In review of his symptoms, he reports pain while having bowel movements. The way he describes this pain is a stabbing pain. Even sitting worsens the pain. He has a sensation of incomplete bowel movements along with straining. There's urgency, gas, bloating, and cramping with meals. Especially with the cramping, he would report that the cramping would start 5 to 10 minutes within eating, and once the cramping started, he would just stop eating altogether. He would have multiple bowel movements, 5 to 7 bowel movements in a 24-hour period. Usually, the bowel movements were mostly in the morning, which made it difficult for him to eat because he had pain and he had more frequent bowel movements. All symptoms worsened with stress, including anxiety over his symptoms. His most problematic symptom, I always like to ask, what is your most problematic symptom or symptoms? And he reported that if the pain was better managed, he felt like he can eat more. In review of his medications and supplements, he's on ustekinumab every 8 weeks. He's on calcium and vitamin D for his osteopenia. He added on his own L-glutamine, which is an amino acid often with claims that it can help heal the lining of a gastrointestinal tract. There's minimal data in IBD, even though there is some data with patients with cancer, especially with GVHD and bone marrow transplant patients. No other supplements. In review of his food and nutrition history, so he's always been a vegetarian. This is common among South Asians. He recently became vegan. So in addition to, not having any meat or poultry or fish in the diet. He removed the eggs and dairy from his diet after he joined a social media group promoting vegan diets and IBD. There are a ton out there, okay? He also went gluten-free because after reading on the internet somewhere that going gluten-free will reduce his inflammation. So this is no wheat, no barley, no rye, no malt. And then he also removed most foods with fiber because fiber, he felt, worsened his pain and increased the frequency of bowel movements. So now we're wondering what's left, right? So with that said, he primarily had just one meal in the day in the evening, and it would just primarily lentils along with a rotation of small amounts of cooked vegetables. He would include like a dairy-based yogurt once a day, and he would have white rice with that meal. And then from there, he added about 6 bottles of high-protein vegan shakes that he would drink daily throughout the day. And that was kind of bringing him about 1,800 calories in the day. He expressed significant fear of adding foods due to the pain. And he lives with his mother, who does all the grocery shopping, meal preparation, and cooking at home. It's always important to find out who's involved with the meals. It's really learning a little bit more on who is going to support this patient in making sure meals are implemented a certain way. So I'm going to circle back to the case in a few. So diet is considered to be one of the environmental risk factors in the development of IBD. From earlier studies, an increased intake of refined carbohydrates. These are the foods that are non-whole grains, foods with added sugar, and certainly carbohydrates that do not have much fiber. And certainly foods are high in omega-6 fatty acids that are primarily found in animal protein and fats. And then a diet low in fiber. Just to kind of reiterate, fiber is only found in plant-based foods with fruits and vegetables and whole grains and legumes. So a diet low in fiber, especially of fruits and vegetables, were thought to favor the synthesis of pro-inflammatory cytokines, lessen intestinal permeability, and change the gut microbiota towards promoting and stimulating inflammation, and all which may increase the risk of IBD. How fiber can be protective towards inflammation is that we as humans do not have the ability to digest fiber. However, our gut bacteria can through the process of fermentation, in which the byproduct short chain fatty acids may help promote an anti-inflammatory environment within the gut. And then finally, there are 4 levels of processed foods. So the ultra processed foods, which is the 4th and highest level of processed foods, these are the foods that may have more additives and preservatives and emulsifiers and thickeners. And it's considered to be an emerging risk factor to IBD as well, due to possible changes to the gut microbiome. So why is diet of interest in IBD? So one aspect is that diet is a non-medication route. It is seen not to have any side effects because, again, it does not involve medication. It's just foods, right? And then certainly it is seen as a natural way to treat IBD. And then certainly, patients, they want to have more control over their IBD course and quality of life. So certainly with that said, having them being able to make their own food-related decisions on their own kind of fits that, giving them that more control. Overall, there are several reasons why diet is of interest in IBD. For one, is to restore the microbiome towards a non-pathogenic microbiome. 2 is to decrease inflammation through, additions of certain foods or removal of certain foods. 3 is to resolve symptoms: pain, altered bowel habits, gas, bloating, cramping. And then finally, there is a high interest of not being dependent on medications, especially for lifetime, all in hopes to induce and maintain remission. So what we know about diet is that it can help reduce symptoms. It can certainly help address other nutritional concerns for a patient with IBD. The data is inconsistent on whether it can completely resolve inflammation at this point, and the recommendation still continues, and we'll talk a little bit more about this, that medical treatment still continues with any implementation of diet. Okay, so with that said, traditionally, the claim for a diet in IBD, and I was trained this way too back in college many, many years ago, is that, a diet in IBD is to really restrict residue or fiber. There is a difference between the two as an effort to reduce the passage of stool antigens through the inflamed bowel and overall to reduce the frequency of stools to promote comfort for the patient. There's very minimal data for any of this. So to start with low residue, there's no standardized definition for residue, but this term really is still circulates the internet this day. Patients come in with handouts, but it is a term that's been around for over 200 years. And I know this because I have the articles from many years ago stating low residue diet studies. And if any of you are interested in that, I'm happy to send them over. So residue, either it's any food that increases an increase in stool, or it just refers to stool regardless of volume. So which one is it? So with that said, residue can be any food where it could be fiber or no fiber, or it could be meat, it could be dairy. So can you imagine, when one is pulling up a low residue diet handout that they want to follow, it may involve mass eliminations of any food considered to increase residue. It's actually quite restrictive. An early study back in the early 1900s, these researchers assessed residue in an animal study, and they gave a lot of different foods to dogs, and they measured residue output from these dogs, and they concluded that a diet that is low residue is just lean meat, white rice, hard-boiled eggs, sugars except lactose, and small amounts of fruit juices, tea, and coffee. And that was their definition of a low residue diet almost 200 years ago. And you ask yourself, like, oh, who eats that way now? But I can't begin to tell you how many patients have come my way doing mass eliminations of dairy and fiber in an effort to follow a low residue diet. That was the term that was introduced to them by a provider, or they found something on the internet. So it's really important that there's minimal data to support a low residue diet. And then moving into the low fiber diet, as I mentioned earlier, fiber is a part of plant-based foods, again, fruits, your vegetables, your whole grains, your legumes, and it's only focused on plant-based foods. And again, I already stated the reasons why a low fiber diet tends to be restricted, but overall, again, really minimal data. And what in an earlier study in the maybe early 1980s, where they assessed a low fiber diet in Crohn's disease, where they had 71 active adult patients follow a low fiber diet and compare it to a group that were following just a regular diet without any restrictions. And they found no difference in outcomes between hospitalizations or surgical complications and so forth. And then with ulcerative colitis, there's very minimal study. So now the conversations have really shifted from restrictions of fiber to additions of fiber. Okay, so there are 12 diets out there for IBD at this time. And knowing this, I am not surprised that patients have so many questions on what diet to follow to treat their IBD. It is beyond the scope of the talk today to review each diet in detail, but I will highlight a common theme with most of these diets. It involves varying restrictions of carbohydrates, particularly with the removal of lactose through dairy or just dairy altogether, grains like your breads or your pastas, and then certainly with anything with added sugars. All diets, though, on some level will allow fruits and vegetables and some legumes to be consumed as the main type of carbohydrates, in which all have fiber. And I want to also point out that fiber is also a carbohydrate. However, it's a minimally processed plant-based food as well. So, which is why there's also a focus on bringing in fiber as a whole natural food. And certainly with the current evidence, it does not support specific diets as a primary treatment for IBD. As with any treatment, discussions with patients should involve reviewing the claim of the diet, pros and cons, any potential changes that may occur with health or symptoms or lifestyle and excess, and certainly the importance of continuing with medical treatment along with implementation of any diet, because I find a lot of the patients that come my way, they're so eager to get off their medications and look into diet as a sole treatment of their IBD, and it's something I do not recommend at this time. So moving into malnutrition, in addition to unintentional weight loss, malnutrition also includes less intake from the diet. This could be food elimination, this could be skipping of meals, and this occurs over a prolonged period of time. And along with that, there could be a loss of muscle mass and loss of subcutaneous fat. This is often determined with a physical assessment. So look at your patient. Okay. And then certainly malnutrition may also involve change in what we call functional capacity, changes in physical activity and strength, where they're sitting down more, lying down more, they're not moving around as much. And some of the studies have shown that fatigue and symptoms lead to that change as well. Sarcopenia is a term where there is a loss of muscle mass and strength, and it is common in patients with IBD. And I will go over in a second why these patients tend to have more sarcopenia due in the setting of inflammation. But overall, with identifying malnutrition, every clinic questionnaire should include a brief screening tool asking questions on, have you lost weight? Have you had changes in intake? Have you changes in physical activity? There are screening tools out there. It is beyond the scope of the talk today to talk about every single tool out there, but I can throw out a name out there like malnutrition screening tool or malnutrition universal screening tool or subjective global assessment that can be incorporated as a part of the clinic questionnaire. So there are several causes of malnutrition in IBD. So between nutrient losses, changes in food and fluid intake, changes in body composition and anthropometrics, and side effects from medications. So inflammation is a driver here. It's the main driver of malnutrition in IBD. So inflammation is a state of stress. It increases the rate of catabolism where all nutrients, this is your protein from the muscle mass, your fats from adipose tissue, your glycogen from your muscle and liver stores, all of them are broken down in order to synthesize glucose to provide the body as a fuel to heal the inflamed tissue. This is the same process that happens after surgery as well. And then certainly inflammation can also cause damage along the lining of the gastrointestinal tract, leading to poor absorption of nutrients, and thus losses do occur. And certainly beyond the symptoms that can, lead to food intolerances in IBD, restrictive diets where patients themselves just pull out different food groups, and the fear of adding back can also lead to eating less. And then sarcopenia, I already mentioned, it can also, it's related to inflammation, as again, the state of inflammation does pull additional amino acids from that muscle to help heal, and certainly weight loss can occur, as I already mentioned. A patient does not have to have a low body weight just to, they can still show signs of muscle loss and loss of subcutaneous fat, even though they may have a normal BMI or not. And then certainly side effects from medication can lead to malabsorption of certain nutrients, and then certainly all would need to be factored in. The impact of malnutrition in IBD is pretty profound. Certainly in Crohn's disease CD, 65 to 75% can definitely occur there, along with 18 to 62% in UC. And certainly many patients are awaiting surgery for their Crohn's disease to undergo a bowel resection of some level are malnourished. And again, that's a separate topic for another day, but prehab nutrition is a concept where we work with these patients to optimize nutrition before surgery. It's a risk factor for complications after surgery, longer length of stay, slower recovery, and then certainly micronutrient deficiencies can coexist with malnutrition. It's not the biggest indicator of malnutrition because micronutrient levels can certainly go up and down with the state of inflammation, but if one has signs and symptoms of malnutrition, then micronutrient deficiencies may just come in, hand with that. Okay, so with that said, patients, with food avoidance patterns and IBD, patients may change their diet based on beliefs and fears that foods will worsen or resolve their symptoms. So in active disease, they're taking out foods. In remission, even though all their symptoms resolved, they will not add back these foods because they're scared. So long-term food avoidance may lead to avoidant restrictive food intake disorder, ARFID. And I know ARFID was previously discussed by Dr. Che here. So I will just briefly elaborate here that it's really involving an inadequate caloric or nutrient intake followed by one of the following, such as weight loss or, use of oral nutrition supplements, psychosocial needs. There's a significant fear of consequences with food. And there are screening tools available. And again, there's several of them out there. The fear of food questionnaire is something I refer to. And then certainly it is beyond the scope of the talk today, but it is important to include a brief screening tool as a part of this clinic questionnaire. Okay, I'm going to go straight into diet versus nutrient approach because I already touched base on why it's important to include fiber. Okay, so with that said, every nutrition assessment, this is what I do 5-6 times a day where I evaluate intake from every single food group in the patient's diet, okay? Portions, tolerance, likes, dislikes, beliefs, and so forth. And gathering this information helps me understand what the strengths are in the diet, and as well as where are the gaps that I need to help address. And certainly there are two approaches that I use here. And one is like what we know is the diet approach, where we give a patient the name of the diet to follow, followed by a handout of what foods to avoid and what foods to limit. And then the non-diet approach, I don't know what else to call it, the nutrient approach, where I don't necessarily recommend a particular diet, but it's really helping the patient learn their triggers based on the different food groups in the diet and helping them kind of bring all that together. If a patient has so many foods eliminated from the diet, you really have to start building up the building blocks of the diet first before you can even move into meals and recipes and so forth. So with that said, I can stress that diet is not about foods alone. In addition to symptoms and health, what we eat and how we eat is tied to our lifestyle, culture, various eating environments, our emotions, our fears, our beliefs. And this is also can be seen as the relationship to diet. It is often an expression of our food identity. So when you come across patients who are struggling with making changes in the diet, it's really looking at how can we help this patient integrate their relationship with diet, what's being recommended for them. And knowing this, also remember that the patient can have multiple relationships in the diet. Okay, they can have between the different food groups or within different foods in the same food group. So it's a lot to juggle when a patient is struggling what to eat. So with that said, we have to focus on the two for integration for that. Okay, so with that said, focusing on fiber again, there are 3 phases of fiber that I go through with my patients to help gradually add back fiber. Foremost, symptom management is going to be the most important goal. As we know, there are different types of fiber in the diet, soluble versus insoluble, and low fermentable versus high fermentable, and low viscosity versus high viscosity. All have a different impact on symptoms depending on the fiber that is consumed. So in active disease, certainly, I usually like to add one food with fiber in very small portions once at each meal. And then we work out certain options with the patient, cooked, minced, mashed, peeled, and the type of fiber I would select is kind of based on the symptoms at hand. So if they're having a lot of diarrhea, maybe it's oatmeal, maybe it's a banana, maybe it's a sweet potato, chia pudding, which works great for management of diarrhea. Or if they're having constipation, maybe a little combination more fruits and vegetables are tolerable. But it goes in stages, and then certainly more fiber is added through transition towards remission. And then certainly in remission, additional foods with fiber are added at each meal. So with that said, to wrap it up, certainly with our case, I decided not to give him like, this is the diet that you need to follow. There's just so much out of his diet that I need to work with him to rebuild intake from each food group in order for him to build that trust again. So how I work with my patients is like step one, what do we want to add? Step two, what are the portions and frequency? Step three, what are some ideas? And we just start there for like a week or two, and I follow them very closely. So, and it's also input with the patient. He was not comfortable with adding dairy or smoothies or more meals, but he was open to adding more fruits and vegetables and a grain. So we worked out some options that I thought would help him with this constipation, and we figured out a schedule. Another important thing is, whatever foods the patient has in the diet, keep it. They already built some aspects of trust there. Let them keep that. We're going to focus on adding versus restricting. And I asked him to continue to drink all his protein shakes to see if that would help him gain some weight. Okay, and eventually you start with a food group or two, and you move along the way to build a balanced meal with the patient. You teach them how to build a meal again with tolerable foods, which is why I tend to go by one food group at a time with patients that have significant food avoidances, because it helps me help them put the pieces together. And then finally, just in conclusion, is that, we need more studies on the diet and the role in IBD in resolving or, reducing inflammation. But again, having those conversations with patients on pros and cons and rationale can be helpful. And certainly it's not meant for every patient. So patients with significant malnutrition, if you see habits of food restriction, food avoidances, we need to break it down further and how we can add individual foods back in the diet again. And certainly anyone with malnutrition, medical nutrition, and psychosocial interventions. And again, I'm going to bring it back to fiber. It's usually out of the diet for most patients. And just know, even something like, can we start with a food group with some options here and just leave it there, and then let the patient will